Assalamu alaikum. I'm Dr. Aysha, immunologist working in the Bone Marrow Transplant Center. So today we'll be discussing about the immunological workup which is required for the renal transplant. These are the things which are required for the initial workup of the renal transplant patient before we decide that whether the patient is suitable for the renal transplant or not. First of all, the sensitization history. We take the patient history. The sensitization history includes whether there is any prior allosensitization events, like in case of the female, pregnancy, any miscarriages, repeated transfusion, or like a previous transplant. So this is very important. It gives the overall picture about the sensitization event. Then comes the blood group of the patient and the donor. It is very important because blood group should be matched so as to avoid the hyperacute rejection. The blood group of the recipient and donor, they should be ABO compatible. Then comes to the HLA typing. The donor and the recipient HLA typing should be matched. And the more the matching, the more there are the chances of the graft survival. But we prefer that at least A, locus B, and DR should be matched. Last but not the least, the HLA and non-HLA antibody detection is very, very important. These are the two base techniques which we will discuss in the upcoming slides. Then comes to the HLA methods. The serological method is obsolete. We are not doing it, but the molecular method is, we are doing both these techniques. We are doing the HLA method by both SSP and SSOP. And according to the British Transplant Society guidelines for the renal transplant, they recommend that the donor and the recipient typing for the HLA should be by low resolution for at least 5 locus. And they need to determine the mismatches. Now, mismatches are very important. What do you mean by mismatches? Mismatches mean those antigens which are present in donor but not in the recipient. So if there is transplant, there are chances that the patient will develop antibodies against those mismatched antigens. So it just gives the picture about the rejection, so that we need to mention the mismatches. Like for example, you must have seen in our HLA report, we mentioned like 6 by 10 mismatches. So it means there are 6 mismatches out of 10 locus. This is just an HLA nomenclature because in the guideline they have mentioned by low resolution. So what do you mean by low resolution is that we have to mention the HLA typing up to the 2 digits. So like for example, HLA-A hystaric 24. So this is required for the HLA typing for the renal transplant patients. Now, what's the purpose of the cross-match? The basic purpose of the cross-match is to determine the preformed antibodies which are present in the recipient serum as a result of prior sensitization events, which we just discussed previously. And so as to determine the risk. As you know all that the rejection occurs when there is preformed antibodies, and when the preformed antibodies bind to the antigens, and these HLA antigens, they are present on the endothelium of the blood vessels. So when these antibodies bind to the antigens, immune complexes form, and there is activation of the classical pathway, and eventually there is thrombosis and then function of the graft. So preformed antibodies determination is very, very important. Now comes the significance of the DSA. Like, what do you mean by DSA? DSA means donor-specific antibodies. So it has its significance pre-transplant as well as the post-transplant. By pre-transplant, we mean that we have to determine the risk because there are immunological risks, high risk, intermediate risk, and the standard risk. So before transplant, we need to assign a patient a risk, whether the patient is eligible for the transplant or not. Plus, those patients which have DSA in high titer and they need to undergo the desensitization therapy. So after desensitization, we need to determine the DSA. So pre-transplant, DSA has significance in the 2 cases. Then comes the post-transplant DSA. In certain cases, what happens is that de novo mean like those antibodies which are newly formed and they are developed after the transplant. There can be the cases that patient may be flow cross-match, CDC and DSA negative before the transplant, but immediately after the transplant, they are rejection. So in that case, de novo antibodies can develop, and when the clinician suspect and should go for the DSA when there is drastic decrease in the function of the graft, or there has been change in the immunosuppressive drugs, or moreover, the patient is non-compliant. These are basically the risk assessment which I was talking about earlier. And they has been taken from the guidelines, the British Transplant Guidelines. The high immunological risk, when we assign the patient the high immunological risk, it means that patient has antibodies in very high concentration against the mismatched donor antigen. Like, it might be difficult for you to understand, but this means that antibodies which are present in the donor antigen, and we determine it from the HLA typing. So in that case, there is high risk of the hyperacute rejection. For that, we either ask the patient to change the donor, or if there is non-availability of the donor, then we ask the patient to go for the desensitization. But definitely desensitization is the last option, as it's very expensive. Then comes to the intermediate immunological risk. It happens when there is low level of DSA. And in that case, obviously it varies from institution to institution. Certain transplant centers, they do transplant in the case of intermediate risk. But for that case, we need the post-transplant immunological monitoring. Like, we need to monitor patient clinically and by these lab tests for the DSA. And then comes to the standard immunological risk. By standard, we mean when there is no DSA, that the patient is normally, all the DSA tests are negative. This is actually the MFI, the relation of the MFI with the rejection. But here again, it varies from institution to institution. This is just the standard MFI according to the guideline. If there is no detectable HLA antibody, obviously that will fall under the standard. But if it is less than 2,000, then there is minimal risk of hyperrejection. And if the MFI is between 2,000 to 8,000, then we assume that there is intermediate risk, and the flow cross match is going to be positive, and there is intermediate risk for the humoral rejection. I will discuss what is the flow cross match in the upcoming slides. And if the MFI is greater than 8,000, it means that the CDC test is likely to be positive. So we assume that CDC will be positive, and there is increased risk of the rejection. Now, these are the terms which we use for the reporting of the patients. I want you people to know the unacceptable mismatches. When we say unacceptable mismatches, something which is unacceptable. It means that patient has antibodies against those antigen which is present in the donor. So for that case, it's not acceptable. Similarly, acceptable mismatches is that when patient have antibodies against antigens which is not present in the donor. So that would fall in the standard risk. This Sabin's classification 2017 criteria for the antibody-mediated rejection, just the sole purpose of adding this classification criteria was that DSA is not against HLA, but it is for non-HLA2. That for the rejection, it's not the HLA antibodies which are responsible for the rejection. Non-HLA also causes rejection. Because there are so many cases, for example, if the patient and donor, they're actually identical, but still rejection occur. So for that case, we need to assume that there are probably non-HLA antibodies which are responsible for causing the rejection. Now, these are the techniques about the detection of the HLA antibodies. They are basically two, cell-based and the solid phase. The cell-based is complement-dependent cytotoxicity, and the other is flow cytometry, the flow cross-match, and the solid phase assays by ELISA and the multiplex bead array, which is Luminex technology. This is the figure showing about the sensitivity, that which test is highly sensitive. So if we start from the CDC, it is least sensitive. And over there, over the Luminex app, it is highly sensitive. The blue arrows, we are just working on it, inshallah, we'll start it soon. And the green one we have established, and it's available in Immunology lab. It is just the CDC, basically what happened in the CDC, it is basically the actual cross match. When we take the donor cells, having the HLA antigen and the recipient serum, it plays important role in hyperacute rejection. So because we are doing the actual cross-match technique, so it should not be ignored. Once it is positive, so patient is not eligible for the transplant, and we just term it to the high immunological risk. And as the name indicates, the complement dependent, so it detects the complement dependent antibodies. The significance of the complement dependent antibodies are that they are, number one, they are resistant to desensitization. And number two is that they are poor, if the patient is having the complement dependent antibodies, they are responsible for poor graft survival, and they're more responsible for causing the antibody-mediated rejection as compared to the non-complement binding antibodies. However, they have certain disadvantages too. As we just discussed, it has low sensitivity, so it can miss those antibodies which are present in low titer. Moreover, they can show false positivity due to the presence of immune complexes. You people must have seen in the CDC report, there is a column of auto cross-match, where they have written recipient cells and the recipient serum. So the sole purpose of that is just to determine the autoantibodies, whether this test is showing the positive result due to the autoantibodies or due to the HLA. Because we know that autoantibodies have no significance in rejection. And the other disadvantage is that they don't detect the non-complement binding antibodies. Now comes to the flow cross-match. It is obviously has better sensitivity. And the additional point is that it detects both the complement fixing and non-complement fixing antibodies. Now comes the Luminex-based assay. It has basically the three tests. First is lab screen mix. It is basically the screening test, and it is just qualitative test. It basically will tell you about whether the patient has antibodies against HLA class 1 or class 2. If the patient is negative, then we don't proceed for the second or third test. But if the patient has the antibodies, depending upon which class, then we decide whether the patient should go for the PRA or for the single antigen. If the antibodies are present in high concentration and in multiple beats, then we ask for the patient to go for the STAB, the single antigen. But we also take help from the sensitization history also. And for the PRA, we have reserved for those patients which have antibodies, but in not very high titer. And basically, the PRA is the quantitative test. They give the positivity in terms of the MFI. Like, for example, A24, and they give the MFI. So we decide on the basis of the MFI that whether the patient compare it with this. So the single antigen, many centers, they are just doing lab screen and single antigen. But since we are doing a free of cost test, we take very little money from the patient, and we can't do the SAP test for every patient. So that's why we have kept the PRA as well. And it's we decide that whether the patient should do the PRA or the single antigen. Now the advantage
depending upon lab screen.
Exactly, plus the sensitization history. And furthermore, the advantage of this test is it is highly sensitive, as we just see in the previous slide. Plus, it is highly specific because it is detecting the HLA antibodies, basically. Moreover, it plays an important role in the virtual cross-match, which I will show in the upcoming slide. These are the certain drugs which do affect these cross-match tests. So we expect a clinician to just mention if the patient are taking any of these drugs, so that because they give the false positive results, like rituximab, daclizumab, elotuzumab, ATG, and IVIG. They do affect the cross-match results. I just took this table from the guideline. We are not going to go into detail. It is just for us, not for the sole purpose of this is to that these three tests are equally important. CDC, flow cross-match, and the Luminex-based test. And we assign the patient immunological risk on the basis of these three tests. As you can see in the guideline, they have written high risk, intermediate risk, and the standard risk. So when we decide about the patient and we assign the risk, so we have to use all these three tests. Only then we can assign the patient a particular risk. This is another table just showing the risk factors for the antibody-mediated rejection. As you can see, the high risk is those patients which are CDC positive, having MFI greater than 10,000, and which are flow cross-match positive and having antibody against class 1 and 2, and the sensitization history. We don't prefer the patient for the donor, the child or the husband, because due to the prior sensitization during the pregnancy. So that is also considered to be high risk. Then the antibody characteristics, as I just mentioned earlier, that the complement binding antibodies, they are considered to be the high risk and ABO incompatible, or if we take the deceased donor. Similarly, the low risk is when the CDC flow cross-match is negative and the microbead MFI is less than 500, and with ABO compatibility and living donor. This is what I was talking about virtual cross-match. That the disadvantages of the Luminex-based test is that we can perform the virtual cross-match. For example, what we do is that we take the DSA report, and if we have the donor actually typing, we just compare it, and we get to know whether the patient is having acceptable mismatches or the acceptable. Particularly in this area where the donor is living far away. So before calling him, we just decided virtually that whether he's eligible for the transplant or not, whether he should have a further test or not. So this is just the virtual cross-match, not any fancy test. It's just the practice which we do. Then this is just a little about the timings of the cross-match test. The guideline, the BTS guidelines, they recommend that the patient should have, once we have decided the donor, the patient should have at least the cross-match test twice. Once at the time when the patient come to us and we just decide the donor, and the other 14 days prior to the transplant. It is very important because obviously the patient is undergoing so many sensitization events, and particularly if this is the one thing. And the second thing is that if the patient is on transplant list and there is a delay somehow, and the 3 months has been passed, or then the patient should have the antibody testing, all 3 cross-match tests and the DSA. Because the previous results, then they don't, or we do consider, but then we take the current status more important.
There may be new antibodies formation between that period.
Exactly, because patient might be having a transfusion, or if the patient is had the retransplant, so he's obviously on immunosuppressive drugs, and he might be non-compliant during that time. So that's the purpose, actually. That's it.
Thank you so much.
If you have any questions, do ask.
Excellent. Thank you very much, Tanya.
Actually, whenever we do CDC, so in CDC we say that it should be for T cells and B cells.
Exactly.
Is there any significance of doing T cells is more important, or both are very important, and they have, because as I have heard that if they are positive against T cells, even then you can proceed, but if they are positive against B cell, then you should not proceed for transplant. Is there something?
So actually what happened is that T cell we do for the class 1 and B cell we do for class 2. So equally, both are equally important. We can't just consider that if the T cell is positive, we won't do. So they both of them have their equal significance.
So if you said that if CDC is positive, it means if they have a very high chance of rejection, and even they are not responders to the desensitization. So we should reject that.
Exactly. But even then, sir, we have to, if the CDC is positive, so we have to verify whether it is due to the autoantibodies or actually it is due to the DSA. So there is, you people must have seen there's a column of auto cross-match. We call it auto cross-match, which is between the recipient serum and the recipient cell. So it's important. So we just see that.
Other question is, I think, related with this, that if, as you said, if MFI is more than 8,000, it means CDC will be positive.
Exactly.
So in other sense, if we directly do DSA and we are seeing that MFI is less than 8,000, so we should not do CDC or something, or like...
No, sir, we need to do CDC. Okay. Actually, the CDC and flow cross-match is, there is the actual reaction of the donor and the recipient cells. Now, because the DSA is, we just take the antigen from the, it is a bead-based test. There is no actual reaction of the donor and the recipient in the DSA. And this is the actual reaction, so we can't ignore this.
Or similarly, the immunosuppression protocol that we have right now, if this mismatch is less than 50% or 50%, we go for the protocol is that we will do induction with ATG.
Right.
And if the mismatch is less than 50%,
Yeah.
then we don't give ATG, rather we give them standard immunosuppression like tacrolimus, mycophenolate, mofetil, and datacort. Is there any guidelines? This is just वो कहते हैं ना कि सीना बसीना knowledge हम follow कर रहे हैं, but we could not find any. Can you guide us in that?
Sir, I will see, but what I have seen in various institutions, every institution have developed their own guidelines.
Okay.
So they are just doing accordingly. But I will see, inshallah, and I will let
What
you know.
do you recommend for us to follow?
Sir, I will definitely see and I will let you know,
If
inshallah.
you give us the guidelines or the recommendation, we'll definitely follow that, because in that particularly renal transplant immunosuppression, we are absolutely naive. We just want to learn something. This was a great lecture. We learned a lot from this, and we want to apply on our patient all this.
Sure, sir.
And
Yeah, please.
okay. After transplant, I think only DSA is more important for knowing the rejection or
Sir,
after biopsy.
Sir, it depends. It depends. For example, if the biopsy finding, we are having the biopsy finding and it is C4D, so we can do the DSA. But we will see the previous results as well before the transplant. Was the CDC positive or not? Was the flow cross match positive or not? If they were negative, so we won't consider it. But if they were present and very low titer, then we do consider it. So it varied from case to case, actually.
In this, I think the ABU incompatible was, I think you didn't discuss what the protocols about antibody titer pre-transplant protocols. I think the sense how much antibody titer should be.
Sir, for the ABU incompatible, if the titer is 1/256, so it is considered to be high risk. So, and if it is 1/6, then it is like standard risk.
And in post-transplant period, if this PSA turned out to be positive, we should go for desensitization?
Sir, it depends upon, because obviously it depends on, because what is the titer? Actually, what is the titer? Because the recommendations are that if it is above 5,000, then we go for desensitization. So it depends upon what is the MFI actually.
That's why they always ask what is MFI.
So that's basically the means fluorescence intensity, sir.
And what's the test we have available in our lab right now?
So we are doing this Luminex-based test, all these 3 tests, and CDC and flow cross match, we are just working on it. So inshallah, we'll start soon, within a month or so, inshallah.
Any investigation or test, like you explained in your lecture regarding the complement-mediated rejection, which is the cause of hyperacute rejection.
Yes, sir.
So how can we detect that?
The complement-mediated antibodies.
In a patient, for example, patient is at risk. So at the start of the investigation, can we do any investigation to confirm that?
Actually, there is one test which we call C1Q. C1Q, which is available in SIUT currently, and it is basically the subtype of the SAB. So if we are suspecting that there is the complement-mediating antibodies, so for that we can do that. C1Q.
C1Q.
Yes, sir.
And when there's a chart of your Binet classification, can you go back to a Binet classification regarding the non-HLA antibodies? इसे बैक ऑन ये थोड़ा सा एक्सप्लेन कीजिएगा मैडम, मुझे थोड़ा एक्सप्लेन.
Sure, sir. Sir, basically, जो unacceptable mismatches, now we call it, when the patient have the antibodies, we need to take the patient antibody results and the donor typing for this in order to determine it, which I was calling earlier the virtual cross match. It is like, for that we determine it through virtual cross match. What we do is that we see the patient DSA results and we compare it with the donor typing. For example, if the patient has A24 with MFI of, let's say, 10,000. So we'll see in the donor typing whether the donor has A24 or not. If the donor has A24, then we term it as unacceptable mismatch.
मतलब दोनों में अगर एक ही नंबरिंग क्या आ जाए तो
एग्जैक्टली बिल्कुल सर, ऐसे ही है, ऐसे ही है। और अगर उस पेशेंट में अगर डोनर में वो A24 नहीं है तो फिर हम उसको कहते हैं एक्सेप्टेबल मिसमैचेस। तो वो इस तरह से है, मतलब हम फिर इस तरह टर्मिनोलॉजी यूज करते हैं, तो मुझे ये था कि फिर डाल दूं।
Another, I think we usually follow A, B, and DR, but
Yes,
we don't see what is C and what is DQ. So, is there any significance of C as well as the DQ, which as you mentioned?
Sir, mainly these three locus are important. A, B, and DR. They are highly immunogenic. But we have added this because we are doing for the bone marrow transplant. For that, there is another recommendation that they say that only all 5 locus should be done. And moreover, the guidelines for renal transplant, as I just said, they recommend to do 5 locus. So that's why we
have to confirm out of 5 if how many are positive and
yes, we have to do that.
यूजुअली हम रिजल्ट जब देखते हैं तो ABDR देखते हैं तो तब भी उतना ही परसेंट होता है, और जब 5 देखते हैं परसेंटेज यूजुअली सेम होती है। परसेंटेज को जब कैलकुलेट करें तो ऑलमोस्ट सेम ही होती है। सो एक डॉक्टर आयशा, एक लेक्चर इतना इंटरेस्टिंग था, ये बहुत जबरदस्त था, हम इसको बार-बार सुनेंगे इसलिए रिकॉर्डिंग की है। आफ्टर ईद जो हम गाइडलाइंस बनाएंगे रीनल ट्रांसप्लांट की अपने पेशेंट के लिए, तो वो भी एक
ठीक है सर, रिलेटेड ट्रीटमेंट
बेस्ड ऑन दीज फाइंडिंग्स, जो इम्यूनोस्पेशन प्रोटोकॉल हमने इंडक्शन, मेन तो इंडक्शन होता है, मेंटेनेंस तो
प्री ऑफ देते हैं।
यस वही ना, वो तो प्रोटोकॉल हो जाएगा। एक तो इंडक्शन होता है और दूसरा मेंटेनेंस तो इट रिमेन्स सेम, लेकिन जो इंडक्शन थेरेपीज हैं वो डिपेंडिंग अपॉन दीज रिजल्ट्स आपको चेंज करनी होती है। सो दैट वी वांट कि अगर आप उसमें
ठीक है सर, इंशाल्लाह इंशाल्लाह।
तो ईद के बाद जब भी आप कंफर्टेबल हो आप हमें बता दीजिएगा इंशाल्लाह।
ठीक है सर, इंशाल्लाह।
थैंक यू वेरी मच, बहुत बहुत शुक्रिया।